With that, I'd like to introduce the host of today's, Professor Prabha Chandra. Professor Chandra is a senior professor of psychiatry and former dean of behavioral sciences at NIMHANS, Bangalore. She's a clinician, teacher, and researcher, and her work on women's mental health has received international recognition. Her research focuses on reproductive psychiatry as well as the interface of biology and the social determinants of women's mental health. She has been the president of the International Association of Women's Mental Health and is the editor-in-chief of the Archives of Women's Mental Health. She has served as a temporary advisor to the WHO and the UN AIDS and is a fellow of the National Academy of Medical Sciences, India, fellow of the Royal College of Psychiatrists, UK, and fellow of the Royal College of Obstetrics and Gynecologists, UK. With that, Professor Chandra, please take over.
So, ladies and gentlemen, I think we've had some very provocative statements being made from this podium, and of course, some very real issues being raised. What I'm going to do is just going to see a little bit of a summary to kind of, reflect on what Vikram has said. To also discuss psychiatry as it is being practiced, let's say, at a place like NIMHANS today, what kind of research the Center for Brain and Mind, the Rohini Nilekani Center for Brain and Mind is doing, and how it relates to some of the statements you've made. And then maybe focus a little bit on, the way forward, particularly for our country. Yeah. So I think to just summarize, the first thing you said was how depression has not improved. In fact, it's increased in a country like the US, which is a very, very well-resourced country in terms of mental health professionals. So probably more mental health professionals is not necessarily the only answer to improving mental health in a community. Clearly, there's evidence to suggest that. Then you sort of went on to saying the problems with categorical diagnosis. When you put people in pigeonholes, that doesn't really make a difference to care. And in fact, if anything, it hampers it. And this is particularly for the commonest condition in mental health, depression. You then spoke about the great importance of early childhood and early childhood interventions, and the importance of adverse childhood experiences in shaping mental health. You talked about the developmental fragile parts of people's lives, particularly early childhood. I would actually go back to pregnancy when the baby is still not born. In fact, James Leckman has now moved on from early childhood to, preconception times itself, And then, of course, the very great importance of social determinants of poverty, disadvantage, and how it's bidirectional. Mental health problems lead to poverty, poverty leads to mental health problems. Very nice discussion on adolescent stress, particularly on social disconnection and the social comparison and how that relates to social media. And a very, very simple but probably effective, which we will know soon, about the importance of policy in terms of social media. And interestingly, comparing social media to alcohol and tobacco. And I think that was a good analogy of, trying to say that we don't allow people to drink under a certain age. So why should we use another addictive method? Why should it be so freely available? And then, going on to simple solutions like the friendship bench, the healthy activity, and the sort of light touch programs, particularly in the context of staging of mental health problems. Like all mental health problems don't need to come to a big center. They can be managed in the community. The importance of lived realities. So lots covered in a short time. And very interesting last statement about rocket science. So we were designing we were part of a task force for suicides in IITs. And there were IIT physicians, and they kept asking us about IIT physicists, and they kept asking about how will you identify depression? Like, what is the way you identify depression? And I told them, it's not rocket science. So they said, rocket science is easy for us. Identifying depression is much harder. So I think it's very important for us to understand that simple methods are not, which seem very simple to some people, not necessarily very simple for others. So I just want to sort of take a little bit of a, not exactly a counter view, but to kind of say that what is happening in science today, at least I know that, for example, in the Center for Brain and Mind, 3 papers on adverse childhood experiences and subsequent temperamental problems in people, mental health problems, how people with history of family psychiatric illness and having adverse childhood experiences actually increases the chances of subsequent mental health problems. So quite a bit of interest looking at adverse childhood experiences even biologically, number one. Number two is the focus on the transdiagnostic method, and I particularly want you to comment on that. So the current science of mental health is moving away from categorical diagnosis, has completely moved away, particularly in the context of research, definitely, but even clinically, we try not to put people into pigeonholes too much, mainly because of the 2 things that you mentioned. The heterogeneity, the varying ways in which particularly some conditions can manifest, like 2 people with schizophrenia are not the same, 2 people with bipolar disorder not the same. 2 people with OCD might be little same, but they're not the same. So there are conditions. So most conditions, we see a lot of heterogeneity. So now the focus is really on using a more transdiagnostic approach with sort of, the 3 things that you mentioned. Focus on emotional dysregulation, avoidance, and cognitive distortions. The way you think being different as actually being the targets of most scientific research. Right now at the level of scientific research. May not be so much when we actually see patients in the clinic. And also the focus now on what are called unified protocols. That you don't have a separate method of treatment for anxiety, for depression, for another phobia or PTSD, but you actually have something called a unified protocol, which takes the basic tenets of intervention in these conditions. So do you think that these are ways forward from the very categorical diagnosis that people have used?
No, absolutely. I do think that. And, these are, you're right, they're not simple. By simple, we shouldn't, first of all, presume that anyone can do them. You do require skills to do them. But one of the things I will say is that there is a tendency in our society these days to dismiss simple things because, they're not sophisticated sounding enough. And I feel that has grown a lot in recent years. I'm always reminded of my, very dear and late friend Richard Cash, who discovered what is probably considered to be the most life-saving intervention in the history of medicine, which is, of course, oral rehydration salts. And it's interesting how, we consider this like every day, everybody's getting, some electrolyte fluid. We consider it for granted that this must have been like this. It was not like this. Until the 1970s, if you were dehydrated, you had to have an intravenous drip. And I remember Richard telling me that the reason why oral rehydration salts were dismissed by the entire science community was because it was so simple. That any mother could prepare it in her house and give it to a kid. And how could something so simple save a child from cholera death? So I do think that we need to get over that. That some solutions can be very simple. They can be intuitive. They can be actually part of our social, structures. We don't always need a highly professionalized solution. This is not to say for a moment that we don't need professionalized solutions. I'm simply making the case here that that is not the only way that we can address mental health at the population level. And even words like transdiagnostic are again jargon to say exactly the same thing. That there are some simple techniques in life that if each of us are taught, if we learn about them, we're made aware of them, that either we can deploy them for ourselves at moments of distress, but more helpfully deploy them with people around us when we can see that they're distressed, then maybe we could do something to address the mental health crisis.
Thanks for that. Yeah, I just want to know whether you're aware of any interventions, particularly for addressing the adverse childhood experiences, because clearly it seems that that's something that you can actually intervene with. You can do something about that. You know, you mentioned quite a few of them, like neglect, emotional abuse, poverty, witnessing violence at home. Is there any sort of, I mean, these are things that we know. Mm-hmm. You know, we've known for a long time. Now, of course, science and research is giving us more evidence. We look at the association between adverse childhood experiences and brain function. So we are quantifying it, but we already know this. Are you aware of any, or can you give us any examples of simple interventions that have actually worked?
So the interventions that do, there's actually, on the issue of early childhood, one of the problems in the field of mental health is how terribly siloed it is. So there are very many different disciplines, and each approach exactly the same thing, but from a completely different perspective. So, for example, there is a very, very policy-relevant field called early child development, which actually, Prabha, is, in fact, a euphemism for early childhood mental health. And if you look at the literature on early child development, which is a big national program, it's a World Bank program, it actually speaks to the same point that the question you're asking me. So there are many, many interventions that the World Bank proposes to help promote early life, what they call child development, what I call early life development. Amongst those are reducing childhood poverty, which is, of course, a complex but definitely a doable thing. And the best example of that, empirical example, is the Bolsa Familia program from Brazil, which transfers money directly into the hands of the mothers of children who are growing up in poverty. And Brazil is an amazing country because all their data is open access. And they have these large national data sets which link the social welfare data with clinical data and with mortality data. So you can actually link all of these and ask a straightforward question: what happens to those families who receive the cash transfer to their kids 15 years later? You know, no other country on that scale can you address that question. And my colleagues and I have shown that suicide mortality fell by 40%. 40%. No known intervention in public health has ever created such a huge dent. But more immediately, and I think that, in India right now, we have a lot of cash transfer programs happening, actually. And I won't be surprised if those will accrue benefits. Those benefits are not going to come tomorrow or day after. Those benefits are going to come 10 or 15 years later, when the children of those women who are getting the cash transfers now are going to actually see. A lot of people, a lot of the middle class think, we give money to the poor. They're going to use it on cigarettes and tobacco and alcohol. Not true at all. In fact, every single piece of evidence shows the first thing they do is to get their kids school shoes and a little school bag and send them off to school. That's what they do. That's what 90% of them do anyway. The second thing that is also very evidence-based is parenting support. And these are, again, very well-designed interventions that are designed specifically to teach new parents how to create responsive environments. What does that mean? How to teach children how to play. To just, again, remove the jargon, spend time playing with your children, singing to them. In fact, my colleagues in Sangath have a fabulous collaboration going on, which I should tell you because I love it. Some years ago, I was invited to work with the Carnegie Foundation, which is a foundation that was set up by the Carnegie Music Hall, which is a very august classical music performance theater in New York. And they invited me because they knew I was very interested in early child development. And they had developed a program in which they began to use the lullaby as a way to connect a mother with her newborn child, mostly mothers, but also occasionally fathers. And they found that in all the diverse communities in the United States, there was a culture of singing to the newborn baby. And I remember when this lady told me this about this, she was introducing the program. Actually, we were sitting on a stage together because she was a speaker with me on an event. And I suddenly remembered that the only thing I can remember in my childhood, my earliest years of childhood, was my mother singing to me. It's the only thing I actually remember is the song. I actually remember every single word of that song. There's nothing else I remember from the first 5 years of my life. And so I connected the Carnegie Foundation to my colleagues in Madhya Pradesh who are working in early child development program. And it was just remarkable because every Indian community has songs. Every single household has songs. And so we decided to use the medium of something that is very deeply embedded in our culture, in every culture, but certainly in ours, to actually embed early childhood parenting practices, which is holding the baby, looking at the baby, singing to the baby, and then letting that evolve into playing with the baby, because that is what a nurturing environment is. In a nutshell, it's responsive caregiving that responds to your child's needs. Toxic stress is a much more complex issue. Those are much harder to do. Those really refer to situations which are, for example, a violent situation at home. That is much harder to fix. And in the World Bank guidelines, and including in India, ideally that requires a strong child protection system in place. We don't have such a system in place in India, but that clearly is something. We do have a child protection system in place. For those of you who work in child welfare, you'll know, unfortunately, it's even more harmful than keeping the kid at home in many instances. So that part we don't have, but we do have cash transfers, and we could easily have parenting interventions spread across our community.
Thank you. Actually, we currently are doing a pilot trial with a program called Chime, which basically is group singing among mothers who are pregnant in various primary health centers in Bangalore. There's a parallel group going on in London and another one in Zambia and in South Africa, where local songs which women sing during pregnancy, but the lyrics are tuned to sort of more mental health. I need to look after myself and, for my baby to be born well and that kind of a thing. And we have to see what happens. We're just trying to see how to do that. The second one is, of course, as you very well know, there's another very good intervention, which is early childhood, which is called the book sharing intervention, which Mark Tomlinson has developed in South Africa. We are now doing it here, where we are encouraging fathers of little kids, like 2 years or 3 years old, because fathers are seldom involved in childcare. These are books with no words, and you can use them any way you want, and trying to help fathers and mothers to read to their children together, very young, low-income families. And I think these low-touch interventions probably, play a major role to
but so reading with your kid is another very good example. Singing, reading, playing. Basically, these are fun things. The point is that they have to be fun. And, when a parent does that, those of you parents will know immediately, it's a mutually rewarding cycle,
I'm going to open the floor for questions, comments. Please introduce yourself and ask a question.
Good evening to everyone. Sir. Yeah, okay. Hi, good evening. I'm Dr. Varsha Vijay. I'm a senior resident at NIMHANS. I'm currently working with a geriatric team. So I have a lot of questions to ask, but I'll start with one. Firstly, the healthy activity program, was that without any pharmacological intervention? Without any. So in case there was any suicidal ideas and thoughts at that time also, it was not used?
No. Everybody got access to a primary care antidepressant medication. Nobody was denied medication because that's already part of the primary healthcare essentials drug list. We even trained the primary care doctors. We had all what's called the MH-GAP, which is a World Health Organization guideline list. They were pasted on all walls. They were trained. The drugs were available in the pharmacy, etc. Here's the thing. If you work in primary care in India, you'll find two things. First of all, most doctors don't want to prescribe those drugs. It's a very interesting question, why? You have to ask them why. And when you ask them why, they are person-centered. Say, no, but this person's husband is beating them up. I don't think a pill is going to help them. That's the first thing. They are resistant to actually prescribing medication for mental health problems. There are many more reasons too, by the way. I've only given you one reason. And the second is most of the people don't want to take the medicines. So when you take the medicine, take it for a week and stop. So, and this is what we observe, that in spite of giving all the training, making the medicines available, so now no access barriers, the uptake of medicine was less than 1%. So, and this is something you'll find across primary care. You go to any primary care center and you say, you have fluoxetine? They say, yeah, it's there on the essential drug list, but we don't get it. Why? Because we never indent it. And I say, why don't you ever indent it? Because we never use it. And then you say, but 10% of, 20% of your patients have significant depressive symptoms. I said, yeah, we know that. But we don't think that we should be giving them medicine. So there is a real dissonance here.
So since the past 2 years, I've been working with community projects and I have this exact same experience. So apart from this, like you were just discussing, the things that a young psychiatrist is learning today in various medical colleges, apart from NIMHANS, is the structured, only one way of thinking and a very primitive way of thinking, and you're never exposed to the other forms of it. So are there any kind of, assistance from, let's say, NIMHANS or Harvard, something that can be started in such medical institutes so that the quality of care becomes better? As currently, are there any like that?
By quality of care, can you tell me a little bit more? Do you mean the quality of the medical education?
Medical education, yes.
Or for psychiatric education?
Yes, yeah.
Well, that's what
Maybe we can
NIMHANS
talk about
2.0 should be doing.
Yeah.
But to be fair, this is not only true here. It's the whole field is. I think we're at an inflection point really right now in the field of the study of the mind and the brain. And it's an inflection point where people are pausing and asking the same question that I'm pausing and asking in this lecture. Something is amiss in our fundamental assumptions. And what can replace that? You can't throw the baby out with the bathwater. There has to be something coherent to replace it with, or at least to have a transitional period with. And I think you're in that cusp of that right now. What the future looks like, I am just, like I said, I've tried to predict what the future might look like. But for now, what I feel we should do is to reclaim some of the things we used to do, because actually maybe they were not worth throwing out when we came in with the current system, the current model. And I don't know to the extent you use clinical formulation, but when I was a psych resident, we never followed the cookbook approach. This cookbook approach has really become in the last 40 years, where you just have a checklist and you say, okay, this person fits into this box, therefore you're now going to follow some guideline. I don't ever remember my teachers telling me to do that. We used to have this thing called a multi-dimensional way of describing a person. And I can still remember reading Vikram Patel, 62-year-old married man with one son. He's a psychiatrist, lives in Boston half the year. You were telling a life story of a person. Somehow we just knocked that out and replaced it with a code. Vikram Patel, DSM code 354.3. That is what I feel is not very helpful.
Yeah, just to reassure you that we still have the formulation going. Maybe we just never moved on, but whatever it is, it's like...
You should preserve that.
It's like the sort of critical part of our training. Yeah.
So the one last question I have is, do you have any advice or tips so that we can practice it on a daily basis to change the direction of our thinking?
I will say one thing, if in your daily practice, just ask yourself, have you asked the person who you're caring for, what is the most important thing for them? That's it. Just ask them that one question every time, without fail. What matters to you? And then explore in yourself, have you actually done anything to fill that need? I think that if you did that, you will be making a giant step towards person-centered care.
Thank you. Hello. I'm Dr.
Hi, Dr.
Rangashri
Patel.
Kishore.
We'll take her. Yeah. Oh, please go ahead. Yeah.
Yeah, I am so thankful to you, Vikram, for coming and giving this talk, and I had the opportunity to come and listen to you after so many years, actually. What I want to ask you is the new NIMHANS that is planned. Is there any plan, like, in Bangalore, I have been through several times to OPD and due to my brother's condition. it is so cumbersome from morning till evening. It takes the entire day. And I have seen cases where such a intervention has enabled one girl to go back and commit suicide because of that. You know? And can that be simplified for people to go and get examined? I mean,
Yeah, absolutely. I mean, I think it's very important, like I said, that public health care should be available to people very much more easily, much more. People shouldn't be waiting for so long. In fact, if you look at the whole concept of what is trauma-informed care, it is not waiting in lines from, not eating, not having breakfast, waiting from morning to evening. I think the design of our health systems is such that currently public health systems are just completely overwhelmed by the numbers that come. Everybody need not come to NIMHANS is exactly what Vikram is saying. People need not come to the outpatient and wait for such long times. I mean, there are people who can be very easily treated by general physicians, by community health workers, and that will actually decrease the load and the waiting times and only escalate when you need highly specialist care. But I think the whole concept in India is people like to go to specialists. And this is true not just for psychiatry, it's true for every other discipline, that you actually prefer to go to a kidney specialist, to a cardiac specialist. You don't want to go to a physician because you think that physician is not adequately qualified to handle. But that also causes siloed care. So ideally, it's a GP who should be handling most of the problems and escalating problems only if they cannot, or just calling up the psychiatrist and saying, what can I do for this person? So I think we really need to flip the way we are thinking about mental health care, because this is not a sustainable model.
Hi, Dr. Patel. Thank you so much for the talk. I loved it. My name is Neha. I am a biophysicist by training, so mine is a layman's question. I work at the Murthy Trust. I wanted to try and understand, in your opinion, shifting from the categorical diagnostic tools to a diagnostic system that also includes the social context, what would be the three biggest challenges in that? Because that social context varies from region to region and country to country and continent to continent, and you can no longer apply the labels that are sort of more convenient to apply. So what would be the three biggest challenges in making that kind of shift? And then I had half a question in addition, sorry. You had a graph on slide number 4 where you showed the different contributors to death rates and how they're increasing. Is the assumption in that graph that opioid deaths are primarily due to mental illness? Is that correct?
Let me answer that question first.
Sure.
So, it's interesting. Mental health is so vividly present in our social world that another Nobel Prize winner actually helped construct that graph, Angus Deaton. He won the Nobel Prize a few years ago for his work to demonstrate how life expectancy in the United States had plateaued, and in middle-aged white Americans, peculiarly, had fallen, being the only OECD country where life expectancy was actually falling. And almost the entire responsibility for that was to opioid, alcohol, and suicide deaths. So opioid deaths are an interesting, it's a very multi-causal factor, but if you read The Deaths of Despair, and I've read a lot of these books, the one I would recommend most is Dope Sick. It's the psychology of pain that occurs when the world around you ceases to exist in the way that you were accustomed to. You and I will not understand that because we live professional lives where our world has actually evolved in ways that we want it to go. But if you worked in middle America, where your world was around the factory town, where you and all your mates went to this factory in the daytime, all your wives used to meet in the daytime and make kitchen parties, etc. All your kids went to the same school, and all your summer holidays were in the swimming pool area that was in that factory town. And you watched in front of your eyes that factory close down and rip the heart out of your community. There is a kind of psychic pain that you cannot describe. And the problem in the opioid crisis was that was then mixed with the most appalling example of corporate greed. So you put these two together. I mean, essentially we're talking of a drug mafia. Only thing is this is a drug mafia in suits and ties that gave money to Harvard University, for example. And so we have a building called the Sackler Building. But so that's the only difference between Pablo Escobar and the Sacklers, is that one guy is a Colombian, drug smuggler. The others are one of the wealthiest families in the United States. So no other difference. To your first point is more challenging. However, what I want to say is there's a very good way to think about the social world, the exposome that we go through. Some of those, one part of that social world is very distal. And that means it's macro-social, right? Things like inequality. And it can be very easy for you to feel utterly overwhelmed, because that is not something that you and I can change in any individual encounter, whether it's with a friend or whether it's your client. I think it's best for us not to get overwhelmed by those social worlds. Instead, what we need to think about is the more immediate social worlds that each of us inhabits. And by that, I mean the social networks that we live in. All of us live in that. What I didn't say in my lecture is one of the greatest problems with the biomedical reductionist model, especially when it comes to mental health, one of the greatest problems is it treats us as individual autonomous agents, when in fact, every body of science shows exactly the opposite, that we are who we are in relation to the people around us. And our mental health is profoundly shaped by the people around us. And so those are more amenable. And those are not about which part of the world or country you live in. That's about who do you live with. And the skills that are needed to help you and the people you live with in your immediate household, and maybe sometimes if you're, for example, a minority group, like a sexual minority group, it may not be the people in your immediate households, it could be people with whom you have some kinship because of a shared identity. There are very powerful techniques that can be used with those groups that I think are transferable. They can work in any part of the world, regardless of where you are. It's the more distal things, like, geography, etc., which of course are much more challenging. But I would say focus on the immediate social world. In any case, it's the immediate social world that has the biggest effect on your mental health.
Vikram, what are the non-allopathic systems of medicine? Have you thought about what they offer in the context of mental health?
Yeah, so Sudhir, clearly I have become much more aware that perhaps, I started with a very narrow view because I spent most of my early career in the biomedical reductionist view. And my work has taught me more and more that it doesn't always fit. And I've become more interested not just in non-allopathic, by that I think you mean traditions like Ayurveda and so on, just in the perspective of the spiritual self as a very important defining feature of our minds. This is a very gray area and also controversial area for empirical scientists. It feels like mumbo jumbo. But I do think if you look at the anthropological literature, that we have, as a human society, never separated as neatly as scientists seem to think we should, the mind from the spirit. They've always sat together. And to the extent that many of us at times of despair turn to faith, and indeed, here's an interesting example that I draw on in my teaching, is the African American story. It's a very interesting story, which is why I want to say it to all of you. It doesn't answer directly your question on Ayush, but it does indirectly do that. African Americans have had the most appalling history of violence that you can ever imagine. It's like the violence against Dalit people in this country, but concentrated over 200-300 years of really awful history. And that violence continues to this day. You'd think that African Americans, if everything I showed you just now, that disadvantage and violence are such important drivers of poor mental health, and there's intergenerational transmission, which we haven't even talked about, you'd think that African Americans should have the worst mental health indicators. Actually, they have better mental health indicators than white people. Not all, substance use is worse, but mood and anxiety problems and suicide rates are lower. And so I asked a great scholar of African American culture, history, and he's a psychologist at Harvard. I asked him, how do you square this? How do you square the circle? You know, on the individual epidemiology level, but if you look at group level, it doesn't work like that. And he said the reason is the church. You know, the African American church is a profound place of healing, where African American people over 4 centuries have found succor, have found enormous solidarity, have found a place of resistance. And I found this language completely transformative. I couldn't even believe this, you know. And he said, you have no idea what a protective influence African American churches have, and especially African American women who are matriarchs that have protected their children and protected their community. So what I'm trying to say, Sudhir, is that this is a non-medical way of dealing with a profoundly internal clinical state. And in that same way, I believe that maybe these ancient systems of medicine that you're alluding to may also be playing a role in supporting people at times of great mental distress. I just don't know the epistemology of Ayurveda to say whether there's an empirical scientific basis in the way there is for biomedicine. And maybe that's the wrong question to ask to begin with. But you know, that's the only reason I'm a little bit unsure of the answer to your question.
I deliberately didn't use the word Ayurveda because I wanted to hear what you just said. But just in a half question, what about identity? You talked about identity in the context of the African American movement. So do you see a relationship between mental health and identity where you characterize it differently?
By identity, you mean the African, like an African American identity? I don't know whether I'd say it's identity. I think maybe it is identity that then defines a kinship. Because if you remember, for African Americans, if you go back in history, they were, first of all, ripped from completely different cultures. They look black to white people, but actually, it's just like saying we're all one people. We're not. We're like, I just read today in the newspaper that somebody's documented 1,300 languages of India. You know, so that itself tells you we're not one identity. We're millions of identities. But African Americans were treated as black people, like one block. So people who spoke totally different languages, in fact, people who came from warring tribes were suddenly found to be on the same ship, and you know, and the story goes from there. They were ripped apart from their wives, from their children, etc. The church helped forge a new identity, and that was an identity based around race. That was not the identity they came with, because in Africa they were all black. Their identities in Africa were defined by language or by tribe and so on. But in America they became black people. And the church offered them a place where the old identities disappeared, a new identity was embraced, and through that identity, they formed a kind of resistance. And I think to that sense, yes, identity-based politics may help. I see that here, not just here, across the world. I see that with sexual minority populations. I have documented that the membership of an identity-based group for people who belong to sexual minority groups is extremely powerful way of resistance and of healing and of support for one another. So to that extent, yes, identity-based can be very powerful for mental health.
Vikram, I just want to sort of, end maybe with a question. India is a country where urbanization seems to be the norm, more than, everybody's flocking to the cities. Many of the models that you have used in terms of low-touch interventions, community health workers, are probably more not so urban. So what models do we have from countries which have very high urbanicity? Because we know that urban living is so stressful, people are not connected to each other, neighbors don't know each other, languages are different, there's a sense of othering, and of course there's also more violence, more noise, more pollution, more traffic. what do you think, what kind of interventions do you think will work in urban settings?
So that's a great question, Prabha. You're absolutely right. Most of my life has been rooted in rural settings. And, so I don't know whether I don't have the experience to answer your question with strong, confidence. But first of all, to say you're right about the urban setting being quite distinct from the rural setting. Social networks are different. They're not absent, by the way. They're definitely there, but they're different. They're not defined by caste and by other identities. They're defined often by neighborhoods and where you live and so on. But there are very strong social networks in urban settings. What I want to say is the techniques I've described are universal because they're rooted in human biology. There won't be a separate set of techniques for people in Bangalore from people in rural Karnataka. The question is, how do we leverage the different social networks in urban settings in order to be able to support one another? I don't have the direct experience of that, but in rural India we use community health workers, and we use other existing kind of social networks like self-help groups. I think some of those could be transferable to urban settings. I don't know if Karnataka has it, but in many parts of Madhya Pradesh, which is my main area of work right now, there are ashas in urban settings as well. There are now community health officers. So as much as the health system structures are beginning to look more and more similar in urban and rural, but definitely social networks are very different. And some people tell me that actually in urban India it should be easier because some of the old dividers, like caste, they haven't gone away, but they're less dominant in urban India than they are in rural India. And so actually maybe there might be far more plural and diverse social networks to leverage here.
Yeah, I think it's, like you said, the principles are the same. We just need to see how to deliver them and who will deliver them and where they will be delivered. Because I think, will it be delivered on a metro station or a workplace? Because
so the friendship bench, by the way, that the slide I showed from an African setting is a good colleague of mine, and Prabha knows him as well, who uses grandmothers to provide support to people who are depressed and anxious coming to primary health centers in the city of Harare. That model has now been used in New York. And our model, actually, come to think of it, I should have answered that because now I remember the Healthy Activity Program was adapted and in many, many places now. But in the United States, one of the places we're working with is with a coalition of 32 churches in the state of Texas, of all places. It's called the Congregational Collective, where members, again, this is a reflection of the power of faith, which is, the US is like India in many ways. Deeply religious country, very, very deeply religious. And, church membership is a very powerful force for, creating groups and solidarity. And so these members of the churches, the leaders of 12 denominations, are working with us to have members of their congregation learn the Healthy Activity Program and deliver it to others in their communities as part of their social mission. And so, to the extent that, and that's a fairly urban, it's San Antonio, which is it's like a city with an airport, etc. So to the extent that you leverage a totally different mechanism, a different platform, and what Dixon is doing, the same with New York. He's in African American neighborhoods of New York and Brooklyn and the Bronx. They have exactly the same idea. Ordinary people getting trained, but of course there is a whole cascade system. You're not just training people and sending them out. They're also then being supported by more specialized people. So that's the important thing. It's not a one-size-fits-all. It's neither just psychiatric diagnosis and pills, nor is it just community. It's about ensuring every person gets exactly what they need.
Thank you. I think on that note, we'll end today's evening discussion. Thank you, Vikram, for, as always, making us think, and thanks for a great audience. Thank you.